Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Avyudhya Verma. Sir is MBBS, MD Medicine, DNB, FSCE Associate Professor at the Department of Endocrinology at Index Medical College, Indore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is diabetes microvascular complication. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
So, good evening, friends. As we all know that type 2 diabetes mellitus or hyperglycemia in acute and chronic conditions lead to various complications, and these are mainly divided into micro and macrovascular complications. And although this is a very vast topic, I would be uh, going a bit in brief about the microvascular complications in type 2 diabetes mellitus. So these are some to name the acute complications. We may have diabetic ketoacidosis or hyperosmolar hyperglycemia, non-ketotic coma, and hypoglycemia also in our patients, because we cannot always talk about just high sugars. Our patients are now prone for hypoglycemia also, because we go for tight sugar control. And then talking about the chronic complications, as I said, we have micro and macrovascular complications. And here you can see the same things which I have told you earlier: the acute complications, ketoacidosis, and hyperosmolar non-ketotic syndrome. Then chronic, we have microvascular, where I would be talking in brief about the microvascular diseases like eye disease, kidney, and neuropathic. Microvascular is a total different story, where it includes the brain, heart, and the extremities. So, coming to our topic of microvascular complications. So, before this, we should understand the legacy effect, which says that the blood sugar control should be good from the beginning itself, because of the metabolic memory. If the intensive sugar control is good from beginning itself compared to the standard HbA1c control, as you can see in this graph, the microvascular complications are quite less. And studies have shown that in early stage, intensive sugar control can help in reducing macrovascular complications in longer term also. So ultimately, a good sugar control from beginning itself will help us to take care of reducing the micro and macrovascular complications. And this is a very good Indian data, where this was basically a cross-sectional study of type 2 diabetes mellitus who were diagnosed within 3 months of their first visit after the type 2 diabetes mellitus started. Out of these 4,600 patients, 67% were males, and they were newly diagnosed patients. Majority were between the age group of 41 to 50 years, which were 40%. And they, surprisingly, you can see here, 13.15% had newly detected diabetic had neuropathy, 6.1% already had a retinopathy, and 1% had nephropathy. So you can see these are newly diagnosed diabetic patients. And obviously, not in detail, but yes, we should talk about macrovascular complications like hypertension, obesity, and dyslipidemia, which were present in almost one fourth of the patients from the beginning of diagnosis of diabetes. That's why I was talking about intensive sugar control from the beginning only. And mind it, 6% of these patients were already suffering from ischemic heart disease. That's why we now talk about taking care of the kidney and heart from the beginning, or what we nowadays they say CKM control, the kidney, cardiac, and metabolic control from the beginning, the diagnosis of diabetes only. Here you can see these are all prevalence of complications: micro neuropathy 13%, retinopathy 6%, nephropathy 1%, ischemic heart disease 6%. So this is, you can see, from beginning newly diagnosed type 2 diabetic patients. And as everybody knows, all these can be prevented by strict metabolic control of glucose. But yes, macrovascular complications require more effort, more con- better control of dyslipidemia, hypertension, and other risk factors of cardiovascular disease. And this is the main pathophysiology, the main culprit. As the blood sugar level increases, I won't go in detail, but through polyol pathway, hexosamine pathway, glycerol pathways, and advanced glycation end products, they increase and they cause damage to these various micro and macrovascular organs. So, to begin with, the first microvascular complication, diabetic retinopathy. It is a sight-threatening microvascular disorder, and it affects all individuals with diabetes mellitus. It is characterized by gradually progressive alteration in the retinal microvasculature, and it is one of the leading causes of blindness. And diabetic patients are 25 times more at risk of developing retinopathy compared to normal population. Somehow, the risk in type 1 diabetic is more than type 2. Type 1, we can see at 5, 10, 15 years, the prevalence of 25, 60, and 80% respectively. And proliferative diabetic retinopathy is seen in about 67% who had diabetes for 35 years. And in type 2 diabetic mellitus, almost three-fourths of the diabetic patients have some mild or maybe severe form of diabetic retinopathy after 20 years of duration. So this is, there is some, you can say, increased risk in type 1, but definitely type 2 also the risk is there. So you can see here that we have so many people worldwide with type 2 diabetes. One third have retinopathy and one tenth have vision threatening retinopathy. And type 1, it is more. And among these patients with di- diabetic eye problems, two-thirds develop proliferative diabetic retinopathy and one-third develop diabetic maculopathy. So at the time of diagnosis of type 2 diabetes itself, patient should be screened for diabetic retinopathy, and thereafter annual checkup should be there. So this is the whole pathophysiology. Again, I won't go in detail. There are problems with retinal blood flow, the basement membrane thickening, various growth factors, retinal hypoxia, and this retinopathy, or you can say retinal neovascularization, which leads to the diabetic retinopathy. And here again, the vascular endothelial growth factor leads to leakage and hypoxia, leading to hemorrhage, exudates, vascular leakage, causing non-proliferative diabetic retinopathy or macular edema on left side and right side. You can see here hypoxia leads to the neoangiogenesis, new blood vessel formation, and the increased chances of bleeding leading to proliferative diabetic retinopathy. Risk factors we all know, as the duration of diabetes increases, the risk increases, age of onset of diabetes, lack of sugar control, associated renal disease, hypertension, and dyslipidemia. Then we have low hematocrit also, some ethnic and genetic predisposition, obesity also, socioeconomic. In poor people, it is seen more, and obviously, diet and nutrition are not good there. Clinical findings, I won't go in detail, but yes, we can see microaneurysms, cotton wool spots. Then we have reflexes on posterior hyaloid membrane, intraretinal microvascular abnormalities, venous caliber abnormalities, and featureless retina. You can differentiate here. You can see here the normal fundus and the non-proliferative diabetic retinopathy, where we have these blot hemorrhages temporal in the macular area. You can see the arrows here, and the cotton wool spots, venous beading also seen clearly. You can see here, and the Irma vessels. So you can see here very clear, nice photograph of most of the NPDR problems. And here this is the intraretinal microvascular abnormalities on left side, and on right side you can see here venous loops also with nerve fiber layer infarcts known as cotton wool spots. So in mild NPDR, we have microaneurysm. Moderate, we have microaneurysm, but less severe. Severe, we have more than 20 intraretinal hemorrhages, venous bleeding, IRMA, and proliferative. We have new vessels elsewhere or around the disc or periretinal areas, or sometimes vitreous hemorrhages also. Management, obviously, annual screening, good sugar control, BP control, lipid control. Not well, then maybe laser photocoagulation, anti-VEGF therapy, which is the main factor leading to both the hypoxia and the other factors, the intraocular steroids also to reduce the inflammation, and there are some emerging treatments modalities also. Regular retinopathy screening is required. I won't go in detail, but yes, it is required with fundus, fluorescent angiography also sometimes. We have retinal photocoagulation, laser photocoagulation, anti-VEGF therapy. Assessment is done monthly with the anti-VEGF therapy. We have some PRP also, injectables, which are lower cost and requires fewer patient visit, but it has got some disadvantages also. Then we have pars plana vitrectomy also. It is reserved for people who have non-clearing vitreous hemorrhage and traction detachment from the proliferative retinopathy. Then we have, as I said, intraocular steroids also. Other imaging treatments. Yes, this is good. This is topical brimonidine and somatostatin, which could halt retinal neurodegeneration in patients with type 2 diabetes mellitus and blockage of the RAS system with enalapril and losartan. We all know in kidneys, we have seen that how the blockage of RAS helps our patients. Again, candesartan also, same thing. Tetracyclines also, because they possess neuromodulatory and anti-inflammatory properties. Then coming to the next problem, neuropathy. So this is basically the presence of symptoms or signs of peripheral nerve dysfunction after exclusion of others. So the diabetic neuropathy is basically a diagnosis of exclusion. And what Santonio consensus says, demonstrable disorder either clinically evident or subclinical occurring in the setting of diabetes without any non-diabetic causes, including manifestation in somatic and autonomic parts of the PNS. And this is, you can see here, the diabetic neuropathy, where it is about 50%. So a lot of studies, they say around 25% diabetic neuropathy can be seen in our patients. Then we have peripheral nervous system alteration in neuropathy. And here the longest sensory axons are affected first. So sometimes we see that the problem starts from the toes of our feet because they are the longest sensory fibers, and then they move upward in the stocking and glove pattern. And this is basically the dying back of the terminal sensory axons with relative preservation of cell bodies, and there is a Schwann cell damage due to chronic hyperglycemia. And this is the diagrammatic representation that how there is a degeneration, demyelination due to ischemia, chronic hyperglycemia. And we have different diabetic neuropathies. We have symmetric form and we have focal and multifocal forms also. Symmetric are diabetic small fiber neuropathy and large fiber neuropathy. Then we have mixed also. Then we have autonomic neuropathy, where they involve the cardiovascular, gastrointestinal, urogenital, pseudomotor, hypoglycemia awareness, and abnormal pupillary response. Then we have focal and multifocal forms. Well, we have mononeuropathy like mononeuritis multiplex and isolated cranial or peripheral nerve involvement. Then we have radiculopathies like radiculoplexus neuropathy, thoracic, and diabetic myopathy. So these are both, you can see here, symmetric and focal and multifocal forms. So this is, you can see here, the sensory peripheral nervous system is involved, autonomic is involved, we have mononeuropathies, and we have radiculopathies also associated in this. So this is the classification of diabetic neuropathy, where we have diffuse neuropathy, we have mononeuropathy, and radiculopathy. And then we have some non-diabetic neuropathies which are common in diabetes, which we should keep in our mind. The pressure palsies, the CIDP or chronic inflammatory demyelinating polyneuropathy, radiculoplexus neuropathy, and acute painful small fiber neuropathies, which are sometimes treatment induced, which we'll see this thing. And this is the classification of peripheral nerves based on myelination. I won't go in detail. This is most common as distal symmetric polyneuropathy, which is most common. Here both the sensory motor polyneuropathy is involved. Up to 50% may experience this, and the rest patients may be asymptomatic. It can be still there, but the symptoms might have not appeared. And in diabetic patients also, up to 10% of neuropathy can be attributed to non-diabetic causes also. So that also we should keep in mind. And here we have large and small fiber neuropathies. We have focal and multifocal neuropathies also. I won't go in detail of this. We have peripheral neuropathies also, which can be due to vasculitis and subsequently ischemia or infarction of nerves. And these commonly involved peripheral nerves are peroneal nerve, sural, sciatic, femoral, ulnar, and median nerve. It is self-limiting, can resolve over a period of 6 months, and it should be differentiated from entrapment syndrome because these are kind of local diseases. And this is differentiation between the mononeuritis and entrapment. I won't go in detail. Then we have proximal motor neuropathy also, which is very important. Diabetic MI can be acute or subacute. Usually affects older persons, male with type 2 diabetic mellitus. Pain is almost universal in all. It occurs at onset, first experienced in thighs, then hips, or then buttock. And we can see here wasting of muscles and weakness. And sometimes concurrent distal sensory polyneuropathy can also be involved. It is associated with weight loss up to 40% because the main lower trunk, the muscle amyotrophy can be seen. So the thigh muscles they become weak, the hip muscles they become weak, and the patient lose weight. And obviously, the management is good glycemic control, pain control. The diabetic amyopathy, again, it is basically due to inflammation and microvasculitis of nerves. Here you can see this is the truncal neuropathy, abrupt, almost unilateral, dermatomal band-like distribution around the chest or abdomen can be seen. Motor manifestations can also be seen. Pressure palsies, yes, as I said, median nerve, ulnar nerve, the lateral cutaneous, meralgia paresthetica, very common, radial nerve, wrist drop, foot drop, medial and lateral plantar nerves. Then we have CIDP also, which also should be ruled out. Yes, sometimes can happen with insulin also. Insulin neuritis. It is basically iatrogenic small fiber and autonomic neuropathy. It is caused by abrupt improvement in glycemic control. So sometimes when we give insulin, the hyperglycemia starts getting controlled very fast and it can cause insulin neuritis. So in these patients, we should try to give supportive therapy also and go with a, you can say, less aggressive sugar control. And these are the diagnostic criteria for treatment induced neuropathy. I won't go in detail of this. So screening, yes, at diagnosis of type 2 diabetes only, 5 years after diagnosis in type 1, and then annually in all these patients. So here you can see how screening is important for all our individuals. The diabetic retinopathy also we have seen, the diabetic neuropathy we have seen. And now we come to the screening, how we can see this by temperature or pinprick sensation and vibration sensation also, and annual 10-gram monofilament also to assess for the feet at risk for ulceration and amputation. So these are very simple things. We can keep all these things in our clinic and it just takes 2 minutes, but very important to save the patient's limb. And obviously look for the combination of typical symptoms and signs, particularly the symmetric distal sensory loss and typical signs on examination in the absence of symptoms, or only the presence of a painless foot ulcer which patient has not noticed since long time, because it is painless. So these are, as I have told, some of the differential diagnoses of diabetic neuropathies which we should keep in our mind before labeling somebody as having a diabetic neuropathy. So this is how we do the monofilament test, the tuning fork test. Then we have good machines also by thesiometer for this thing. And here you can see how the autonomic nervous system, when it gets involved, leads to dry feet, fissuring, infection, abscess, and ulcer. So most of the time we advise our patients to not let their feet become dry if they've started autonomic neuropathy, and ultimately this happens, including deformity also. There are some of these newer tests also, but because of paucity of time, won't be able to discuss this. We have international working group on diabetic foot stratification also, but ultimately the cornerstones of management: lifestyle, normoglycemia, reducing the blood pressure, dyslipidemia, and yes, sometimes now we have nutraceuticals also, which in few data have shown that they may help. And obviously it is quite painful, so pain management is also important. Glycemia control important. Then we have all these things: the exercise, the balance training, anti-sedentary behavior, diet modifications, foot care, daily basis patient should impact. Pain management: 30% of these patients they have pain, so we have to give them painkillers. We have gabapentinoids, we have serotonin, norepinephrine reuptake inhibitors, tricyclic antidepressants, sodium channel blockers, opioids, and topical therapies also. So all these are the mechanisms of various drugs. I won't go in detail. We have pregabalin, gabapentin, duloxetine, viloxazine, and amitriptyline also. And we have sodium channel blockers. Sometimes we may require lamotrigine, valproic acid, but they are not considered as initial choice because of that. Tramadol can be given, or tapentadol can be given to reduce the pain. This patient capsaicin patch can be given to take care of the numbness, tingling, or burning sensation. So these are the drug classes: the SNRIs, the tricyclic antidepressants, and gabapentinoid anticonvulsants. Nutraceuticals, yes, they favorably influence the underlying neuropathic benefits. So basically, they provide health benefits. And for this, we have alpha lipoic acid, which has shown promising benefits: benfotiamine, B12, vitamin D, E, acetyl L-carnitine, gamma linoleic acid, and magnesium. They've all shown to help. They may not be able to treat, but yes, support the whole treatment therapy. So now, last microvascular complication, I'll talk briefly about nephropathy. Diabetes is the most common cause of kidney failure, requiring kidney transplantation of dialysis worldwide. And these are one or more of the following conditions. If they are present for more than 3 months, we may say that our patient is having diabetic nephropathy. If the EGFR is less than 60 ml per minute per 1.73 meter square, if the urine albumin and creatinine ratio is more than 30 mg per gram, urinary albumin excretion spot rate is more than 30 mg per day, we can label. But this should be more than 3 months, so there should be at least 2 or 3 samples which say over 3 months that these are present and consistently there. Lifetime prevalence of diabetic nephropathy is 30 to 40% in type 2 diabetes and almost same in type 1 diabetes mellitus. Risk factors are old age, male gender, Black Americans, Native American, Hispanics, Asians, family history of diabetic kidney disease, prematurity, short for gestational age, and exposure to maternal diabetes. And obviously, hyperglycemia, obesity, hypertension, toxins, smoking, high protein intake, they are all risk factors. And this is the natural history of diabetic nephropathy as given by Mogensen. This is very important. You can see here, initial we may have increase in the GFR, but then along with this we have microalbuminuria and hypertension, and then we have the overt diabetic nephropathy, which is like respectively 0 to 5, 5 to 10, and 15 and above years, where we get proteinuria nephrotic syndrome and reduction in the GFR. Ultimately, what happens? Initial, there is a renal hypertrophy, mesangial expansion, GBM thickening, and the mesangial nodule formation. So this is the whole natural history. Screening: type 1 yearly, starting 5 years after the diagnosis. Type 2 yearly from the diagnosis itself. How to screen? This is important. We can get a spot urine ACR and a GFR also. Here, mind only creatinine is not sufficient. And what to do if we get a single positive result? Repeat and confirm it. Whether it is due it is temporary or due to some spurious causes. Consider using cystatin C and creatinine to more precisely estimate GFR, and only if there is persistent abnormalities, then only define it as a CKD and definitely initiate evidence-based treatment. And how we can say that this patient is CKD according to a test if there is a persistent urine ACR more than 30 mg per gram and or persistent EGFR less than 60 and or other evidences of kidney damage. So what we should consider: causes of CKD other than diabetes? Yes, other systemic cause also, especially when retinopathy is not involved. So, whenever we diagnose a patient with nephropathy, we should get a retinal examination also, because almost, you can say almost 100% of the diabetic nephropathy patients have retinopathy. So, we should get a retinopathy. Then only it helps us to confirm that this is DKD. And when the CKD signs are not common to diabetes, like glomerular hematuria can be there, large and abrupt changes in EGFR or albuminuria, or some other abnormal serology tests. Pathophysiology, again, I would say it is same: hyperglycemia, various hemodynamic abnormalities, the inflammation, fibrosis, and obviously, as I did earlier, also some epigenetic changes also. The detail I won't go in. The hemodynamic changes, metabolic, inflammatory, and fibrotic changes. These are all those diagnoses. I think I've told earlier. I won't talk much about that. We have this histological staging, class 1, where we have glomerular basement membrane thickening, mesangial expansion, nodular sclerosis, and then we have advanced diabetic glomerular sclerosis, where we have more than 50% diffuse global glomerulosclerosis with or without nodules. And here, these are some of the patients, the drugs which needs to be altered in dose while our patient is having a diabetic kidney disease. When we should refer to a nephrology? When the diagnosis is uncertain, whether it is due to diabetes or some other cause. When we have hypertension which is difficult to control, when there is fluid overload, when there is anemia which is responsive to oral iron, when we have abnormal bone chemistry, EGFR is between 30 to 35, patient is having nephrotic syndrome, and we have EGFR fall more than 5 ml per minute per year, then we should think of a aggressive treatment with the help of a nephrology. So, what are the treatments here? Comprehensive care, as I said earlier, also good weight, regular exercise, no smoking, giving drugs to control the hyperglycemia, lipids, blood pressure, the proper nutrition, and now we have good SGLT2 inhibitors also, which are helpful in taking care of the EGFR and the increased proteinuria. And a small word about metformin. It can be used. It's not a totally banned drug for DKD patients, but only if the EGFR is more than 30. I would say less than 45, reduce the dose to half, and less than 30, don't use it again. RAS blockade, yes, important. Now we have a good non-steroidal mineralocorticoid antagonist like finerenone. It reduces the risk of CKD progression along with reduction in CV events. and residual can be used in patients with type 2 diabetes mellitus with ACR more than 30 and normal serum potassium. This is the whole chart how we can take care. So overall, these are my four pillars. Reduction in diabetic complications, whether they are micro or macrovascular complications, glycemic management, blood pressure, lipid management, and agents. Nowadays, we have available new OHAs also, which can give extra cardiovascular and kidney benefit. So, we have to take care of hyperglycemia, reduce the micro and macrovascular complications with a good control of dyslipidemia, hypertension, and other risk factors. Thank you.
Thank you so much, sir, for answering
So,
all our
if we have
questions.
any questions, you can post it here. Yes, okay. So, we have one question
Yes, sir.
that how do you stratify diabetic patients for risk of developing microvascular complications?
That's
So,
right.
I would say it is basically difficult to stratify the patients, as I told in the said in beginning itself ki, it is basically the from the diagnosis itself of type 2 diabetes mellitus we should start screening these patients, because 5 to 7 years before the diagnosis of type 2 diabetes mellitus, the hyperglycemia, the insulin resistance has already started damaging the microvascular and macrovascular architecture. So it's basically, as I said, the risk factors also play an important role, the comorbidities also play an important role. So more the risk factors, more aggressive treatment and diagnosis should be there. Then our next question is, what are the potential complications associated with treatment for diabetic macrovascular? How do you mitigate this risk? Yes, see, basically, we should understand before any treatment that the patient has already damaged the architecture, the vascular architecture. So our aim first is to halt the progression of whether a micro or macrovascular complications, and it is done basically the it depends on person to person according to the comorbidities again, that what complication they would be like. See, if I take about the neuropathy, if somebody is already having a loss of sensation, then definitely, even if I give a good management of pain or some other thing, he or she may not have good response in the control of the pressure ulcer, because it has already developed, the architecture has already changed, the ischemia, the neuro problems have already set in. So sometimes we will just take care, we will not be able to uh, have a good reduction in complication. And yes, this is very important question, that how you manage the hypertension and dyslipidemia to prevent exacerbation of microvascular complication. As told in my first slide, that the main treatment starts from the diagnosis of type 2 diabetes mellitus. So as soon as the diabetes is diagnosed, go for an intensive control until unless there are some contraindication for a tight sugar control. This is the only way to reduce the microvascular complications and in future macrovascular complications. I think again I have talked in brief about this question, the current pharmacological and non-pharmacological management of retinopathy, nephropathy, and neuropathy. I think I have talked in brief. There are a lot of current new pipeline pipeline agents and various therapies also, but I have taken into consideration some uh, uh, the commonly used easily available therapies for management of this because of the paucity of time.
Thank you so much, sir, for answering all our questions, and that's all from our audience. Before concluding, sir, any last remark from you?
Okay, so thank you, uh, all dear friends, for your patient listening and an interactive session. I would like to end my lecture with a single line that don't wait for the diabetic complications to occur. Treat hyperglycemia aggressively from the beginning itself because it has shown to drastically reduce micro and macrovascular complications. Thank you.
Thank you so much, sir. With your permission, I would like to conclude today's session. Thank you.